After studying this module, you shall be able to understand the concept of community-based health insurance scheme, its role, importance and impact on health financing for poor, analyze the constraints in universal health insurance scheme for poor and further prospects ahead, identify the community-based health insurance scheme in India and their achievements and failures. In most of the developing countries, health financing is majorly an out-of-pocket financed expenditure. According to World Health Organization report, more than 80% of healthcare expenditure in India is private, out-of-pocket and progressive. Therefore, in general and in context of India, there is an important question on the means of financing healthcare services. A study by Peters et al. 2002 has shown that approximately 24% of Indians fall below the poverty line once hospitalized. Hospitalization from out of pocket have increased the population in poverty by 2%. The condition of government hospitals do not meet the standards in terms of quality and universal coverage. In India, government health expenditure amounts to approximately 5% of GDP only, much lower than the developed countries, out of which the services are availed by both poor and non-poor. In fact, the richest class is more likely to take in hospital care than poor in public as well as private sector. One major reason in literature for avoiding hospitalization and healthcare services is cost. Health financing systems prevailing in different countries of the world is widely developed through general taxation or social health insurance to provide financial protection against healthcare cost. In tax-funded schemes, individuals contribute towards health financing by paying direct and indirect taxes, which is difficult to develop due to robust tax base. Secondly, in social health insurance, which was originally started by insuring workers and is an organized sector scheme, contributed to health financing through wages and salaries. However, most of the developing countries have failed to achieve universal health financing system, especially to provide adequate health services to poor, sometimes due to organizational difficulties or lack of consensus among the population to develop a common rule of social health financing protection to all determined by healthcare needs and irrespective of contribution or due to political and administrative difficulties. In this context, health insurance appears to be an attractive way out to bear the out-of-pocket healthcare expenses. Many countries have recently turned towards exploring direct community involvement in financing healthcare. One such scheme is Community-Based Health Insurance Scheme (CHI), which is specially designed for poor who are otherwise not capable of meeting their healthcare expenses or buying health insurance from general insurer or other private insurers individually due to financial constraint and is not a part of organized sector so as to get covered under social insurance scheme is Community Based Health Insurance Scheme (CHI). This scheme is specially designed to protect poor population from indebtedness due to health financing and to improve their access to healthcare facilities. In this lesson, we will take a detailed look of CHI schemes in terms of its role, importance and impact on access to healthcare services by poor. We will also describe CHI schemes in India and their success and failures. Finally, we will try to locate the future prospects of CHI and other health insurance schemes for the poor. Next is community-based health insurance. Let us first understand what community health insurance (CHI). CHI is also known as micro health insurance and local health insurance. CHI involves a direct involvement of communities in health financing. Devadasan et al. 2004 defines CHI as any not-for-profit insurance scheme that is aimed primarily at the informal sector and formed on the basis of a collective pooling of health risk and in which members participates in its management. It involves pooling of resources by different members of a community, which may be a social group sharing similar culture common needs and health problems, so as to purchase an insurance either by a third party or managing themselves as NGOs and self-help groups to arrange provision of health services and health care by the providers. There are basically three types of arrangements of CHI in India. Type 1, HMO design. In this design, hospital is the provider of health services as well as the insurer. Type 2, insurer design. Voluntary organizations such as NGOs, self-help groups, etc. acts as an insurer and buys health services by individual providers. Type 3, intermediate designs. This is a third-party arrangement of CHI where voluntary community groups purchases insurance from insurance companies and buys healthcare services from the providers. The schemes of all the three types aim at providing care to poor, especially rural poor in India. Premium therefore is kept low in majority of the schemes, ranging between Rs 20 to Rs 60 per person per year. Diagram 1 has been shown to demonstrate the types of community health insurance schemes in India. Next is health financing subfunctions. World Health Report 2000 analyzed three basic health financing subfunctions of CHIs: revenue collection, pooling of resources and purchasing of services. The empirical evidences in the report claim that CHI in most of the developing country is at a nascent stage and their achievements in regard to sub-functions are minimal. Let us understand each health financing sub-functions individually. Revenue collection. Target of CHIs is universal health protection of poor. Therefore, the population covered by the scheme is a good indicator of its success. Equity suggests that membership should be open for all along with sufficient revenue generation. Higher is the revenue collection, lower the financial constraints on availing health services when needed and less out-of-pocket payments for high-cost health services. A high prepaid contribution by individual thus increases the viability of the scheme. The total revenue collection under CHI depends on individual prepaid contributions and other contributions by government in form of transfers and subsidies along with national and international NGOs and bilateral donations towards health financing. In a WHO study of 13 out of 24 households, cost of less than 60%, that is in absence of any other source of revenue, 40% is the out-of-pocket health care cost. Next is pooling of resources. Membership to CHIs is complemented with pooling of health risk among the members of the community joining the scheme. This pooling of risk creates financial benefits as resources get shared between healthy and sick and ensures fairness in contribution and equity is access to health services. However, in practice, it is more difficult than said as there is possibility of communities not joining the schemes together in the fear that the benefits derived will be more for poor than for an average middle class and therefore are reluctant to subsidize the health services of poor by joining the same CHI schemes. Secondly, the healthy might not make any prepaid contribution hoping that they actually don't need such health insurance, and those who enroll themselves are the leftover unhealthy ones with high risk of claiming the health services in future. As a result, in practice there is actually no pooling of results because Those who join are all high health risk members. As per ILO study 85, CHIs in developing country for which information was available, 47 CHIs has less than 500 members. Such a small size indicates poor financial viability. Next, purchasing of schemes. CHIs need a well-planned strategic purchase of health services. It is an active search of best available health services and health packages in terms of high quality, along with best contracts and payment methods from pre-selected providers. Therefore, strategic purchase is very different from a simple reimbursement scheme where CHI has no exclusive contractual arrangement. Such planned purchases along with best in hospitalization coverage also considers other issues such as geographical constraints where there is a need to ensure access to inpatient facilities and coverage of cost of transportation through ambulatory services, etc. Strategic purchasing is a complete measure of provision of a rational and cost-effective healthcare services. In an ILO study, only 10 out of 62 CHI schemes across countries have adopted strategic purchasing. WHO study claimed that CHI benefits are weakly defined, though some schemes gradually improved in their role of purchasing healthcare services. Next is the role and importance of community-based health insurance. Community-based health insurance schemes are specially designed to provide quality healthcare services to those who cannot afford them otherwise due to financial constraints. In this section, we will describe the primary role of such schemes and their importance in terms of access to quality healthcare among different vulnerable sections of the society. Access to healthcare. CHI emerged as a means of providing access to quality healthcare among poor by targeting the basic problem of access to health services due to financial constraints. Pooling of resources provides the poor with an opportunity to seek medical care as and when required without considering their poor financial health, as the major portion of healthcare costs are covered under the scheme. Next, protection against poverty and impoverishment. CHIs further aims to prevent indebtedness and impoverishment due to heavy healthcare expenses among poor, which force population close to BPL to under BPL population. However, since CHIs generally charge a flat premium, it tends to exclude poor from target population. Trust build up and promoting overall healthcare. Some of the CHI schemes are self-run schemes operated and managed by their members. This helps in developing a trust factor among members of the group who shares common background like living in same district, same income group, similar kind of occupation, structure, etc. Such an effective local organization helps in dissemination of knowledge about healthcare and importance of health insurance to the community members, and thereby helps in spreading awareness about important health systems goal like good health, responsive health system to individual healthcare needs, and equitable and efficient system of health financing. Low operational cost. The CHI schemes are managed and administered by its members, thereby reducing the overall running cost of the scheme. There are evidences in literature that different CHIs running in many developing countries have together pooled their resources at times to avail specialized management services, thereby enjoyed high grade management service at a low cost. Cater to the healthcare needs of sections not served by private insurers. Most private insurance companies that run for profits introduces exclusion based on economic reasons or the health conditions of the insurer, and if included charge them with high premium. On the other hand, Government healthcare institutions in developing countries are not capable enough to serve the entire country healthcare needs and provide universal healthcare services. Therefore, there is a need to look at health insurance in public domain. CHIs bridge that gap by covering that section of society who cannot enjoy financial support to meet health expenditure through private institutions. Challenges and constraints for community-based health insurance schemes. Number of CHIs are functioning across many developing countries across the world. However, it is claimed that their success rate has remained modest and therefore for policy reforms in CHIs and health insurance sector. It is crucial to determine the factors that has led to such a modest performance of CHIs. In this section, we will try to locate the challenges and constraints faced by CHIs. Adverse selection. CHI is a group-based health insurance scheme with one of its features of pooling risk, that is prepayment contributions by healthy and sick and therefore pooling of resources and division of risk among all the members of the group. However, due to this feature, there is a possibility that the healthy ones opt out and the scheme only consists of high-risk sick population, which leads to high financial burden due to low prepayment resource pooling and high reimbursements at the time of availing medical services, which might result in either high out-of-pocket expenditure even though a person is the member of CHI or low quality health care. Next challenge is moral hazards. There is always a tendency that when an individual is insured and certain about the risk cover, he tends to act carefree. Health insurance might lead individuals to neglect their health and healthy habits when they are insured under CHIs, as now they feel less burdened about the financial health expenses, which therefore results in unwanted diseases and health problems and give rise to more healthcare expenses under the schemes. Co-payments, standard treatment guides are some preventive strategies for moral hazards. Next challenge is low enrollment of targeted population. Poor do not find the schemes attractive due to no immediate benefits, high premium, large families and high cost of individual membership, distance from the providers of healthcare and no requirement of health services every year. All these factors prevent the targeted population to become part of CHIs. Other factors. One of the main constraints in developing countries is to ensure an appropriate health provider as well as credible insurer. Lack of comprehensive health packages, quality services and coverage of indirect costs associated with illness is one of the major constraints to growth of CHIs. Health issues like maternity leaves, TB, HIV, etc. are not covered by majority of CHIs in India. These factors challenge the universal community coverage of CHIs. Proper management of the scheme is another area that needs attention, as CHIs are managed by community members and lack expert management. Next, community-based health insurance schemes in India and overview. More than 20 CHIs are operating in India. Currently, the first one, Student Health Home, initiated in 1952 in Kolkata, West Bengal. All CHIs targeted the poor population in rural and semi-urban areas. Among them, 5 schemes are of Type 1 HMO design, 2 programs under Type 2 insurer design, and the 5 recent CHIs belongs to Type 3 intermediate design, which seems to be the most popular one in recent years. The following are the 12 CHIs in India. Accord, Gudalur, Tamil Nadu, 1992. DAIF, Urali, Kanchan, Pune, Maharashtra, 2001. Buldhana, UCCS, Buldhana, Maharashtra, 2000. DHAN Foundation, Theni District, Tamil Nadu, 1997. Karuna Trust, Mysore District, Karnataka, 2002. MGIMS Hospital, Wardha, Maharashtra 1981. Nerve Surgeon Trust, Pathan District, Gujarat 1991 but discontinued in 2000. RAHA, Jaipur and Korba Districts, Chhattisgarh 1980. Seva, all districts of Gujarat 1992. SHH, Kolkata, West Bengal 1952. Voluntary Health Services Center, Chennai, Tamil Nadu 1972. Yasaswini Trust, Bangalore, Karnataka 2003. Next are the features of CHIs in India. Among these CHIs, most of which are basically community-based organizations with low prepayment charges, Accord, Karuna Trust, Raha, targeted tribal population, Nerve Surgeon Trust targeted Dalits, VHS, MGIMS, Yasaswini were formed for farmers, women, self-help groups like Dhan Seva are formed. Premium charges by most of the CHIs ranges between Rs 20 to Rs 60 per person per year. Usually payable once in a year in cash, some in kind, Raha, MGIMS. Membership to these organizations remains voluntary and unit of enrollment is individual with some exception with family enrollment, for example Dhan, Seva and VHS. The size of targeted groups range from 1,000 to 25 lakhs Yasaswini. Karuna Trust subsidized the premium amount of targeted population belonging to BPL and also cover loss of wages, insurance due to illness. Many of these CHIs included ambulance service and provided inpatient care but do not cover treatment for self-inflicted injuries, TB, HIV, etc. Providers are mostly from private sector with one exception of Karuna which has a public provider. Most of CHIs are administered by community members that aim at creating awareness among the community, but still the average enrollment rate remains 10 to 50% of targeted population. CHIs such as Dhan, Seva and Raha only cover direct costs, that too with a capping, and not addressed the non-financial barriers and indirect costs that lead to low rate of utilization of these schemes. The main aim of CHIs remains to provide quality services at low cost prices. Next is the further prospects of health insurance for poor. Schemes like CHIs are not directly affected by insurance sector reforms and needs regulatory changes to boost grouping activities. Due to increased competition in insurance sector, profit companies, even public insurers, tend to serve individuals with high profit margins and avoid providing services to poor. Therefore, an appropriate regulatory obligation is required to be imposed on all former insurance to improve future prospects of CHIs. Cross subsidy along with uniform social obligations put in place along with bringing charitable hospitals under insurance regulatory supervision can enhance the pace of managed care arrangements and will be helpful to cater the poorest section of the society. CHIs are an important step in the sphere of health insurance schemes to promote equitable and efficient health financing system. CHIs in different developing countries offer valuable lessons for policy framework. Its main purpose is to serve the poorest and vulnerable section of the society which is otherwise is not capable enough to enjoy healthcare security due to financial constraints. This lesson presented 12 CHI schemes operationalized in India along with their features and their success in attaining their basic objective of providing quality healthcare to poor. CHIs play an important role in attaining and catering to health services needs of targeted population is analyzed. We further located the constraints and issues regarding coverage of targeted population by CHIs and raised the concerns regarding the problems of adverse selection and moral hazards in community-based healthcare insurance. Towards the end of the lesson, we have identified briefly the future prospects of health insurance for poor and the role of CHIs in this scenario, where the role of regulatory authority is highlighted to improve the access to healthcare services by poor.